It's very much an honor to be here, and tough act to follow Dr. Tom Solomon, who's quite a leader in this field. So today I'll be focusing on pediatric encephalitis, and this is a bit of a different talk for me. Generally, I talk about the disease process, the pathogenesis, treatments. So I'm going to do something a bit different, in part because some of the other speakers were covering some of those same items. But I want to take a couple steps back and remind people where we were 20, 30 years ago with this syndrome, and then talk about where we are now, and then talk about some future steps. I will also be discussing, why this is so incredibly difficult as a syndrome to manage. Now, when I first met Becky and actually Bob Morris many years ago, I remember them asking me, well, why is it that doctors don't understand this? Why aren't they able to figure out my diagnosis? And I sort of looked at both of them and I just said, well, let me explain a few things. This is a very complicated syndrome to deal with. Clearly for the patients and their family, but it really for us clinicians in the medical community, it's a very challenging syndrome. Next slide.
Sorry, it's not moving. There we go.
Okay. So just briefly, we'll talk about some of the general background about encephalitis, and then I'll spend a few minutes talking about, when I talk about the past, my perspective as a clinician, and really I became very interested in this when I was a pediatric infectious disease fellow. And then that led me to starting the California Encephalitis Project, where we had a lot of challenges. We had a few success stories, but then I want to kind of fast forward to the present, where there's a lot of incredible things that have happened. I know for many of you that are listening, whether you're the parent or the patient, it's not enough. We need to do more, but we're a lot further along than we were 20, 30 years ago. I will spend a couple minutes about outcomes and recovery, and what advice I would give to parents who may be dealing with this, and then talk about some future steps. So I think one of the first things to remind folks when we talk about encephalitis, this isn't a single disease entity. It's not just one thing that we come in and treat. And if it's an infection or due to infectious cause, it's usually an uncommon presentation of a common infection. For example, herpes infections are very, very common, but every once in a while they lead to encephalitis. Enteroviruses are something that children get almost every day. Every child has been infected with several enteroviruses. But uncommonly, it can lead to encephalitis. Now, in other instances, it may be a rare infection. And in the Dr. Solomon's talk, there was a mention of rabies. Rabies is a devastating illness, and when anyone becomes infected with rabies, it leads to encephalitis. And so, as an infectious disease physician, we have to think about, is it just a common infection that ended up with encephalitis, or is it some rare beast, so to speak? And then we also have to consider, is it non-infectious? So there's a lot of different things that need to be considered when we talk about encephalitis. And as I mentioned, it's challenging for all of us. As a physician, first of all, these, as you're well aware, the patients are often quite ill. So that in itself makes it, just very scary for physicians. And then they present in variable ways. I mean, they often have the underlying theme that they have an altered mental status, but in some cases, you may have patients that have predominant seizures and altered mental status. In other cases, it may be that the patient has altered mental status, but predominant a movement disorder, while other patients may just be literally in a coma. So those variable presentations can be very tricky to approach. And then, as we'll talk about in just a minute, there's so many different entities that can cause it that as a clinician, you have to go through those in your mind and decide, do I need to check for that? Is that treatable? And so it's quite a list that you have to be familiar with. And then at the end of the day, even after you've done a pretty extreme workup, you're often in a situation where you haven't figured it out. And of course, that's really frustrating not only for the physician, but certainly for the patients and their families. Now, unfortunately, and patients don't come in with that answer on their forehead, even if they have encephalitis, let alone what type. And so I think in this area, this is where physicians, they don't want to miss something. They don't want to miss something that's treatable, but they have to really search to figure this out. And it's only until recently that we've gotten better at finding some of these causes. So to give you a sense, if we even just begin to consider under the infectious disease realm, how many things can cause encephalitis. And this is like a laundry list, and that's really what it is. There are so many viruses that a physician needs to consider. Now, and some of these, granted, would only be considered with appropriate travel, but enteroviruses can be found anywhere in the world. Herpes viruses always have to be considered. Paramyxoviruses, bunyaviruses, retroviruses. So it's quite a list that the physician needs to think about when that patient first presents with encephalitis. And then on top of that, as far as other infections, there's a lot of non-viral agents to consider. Now, most people often sort of just automatically think it's going to be viral, but there's so many other things, whether it's rickettsia, bacterial, fungal, parasites, or even prion disease that can either mimic or cause encephalitis. And then finally, this non-infectious entity is just growing every day. Many of you are well aware of the autoimmune encephalitis, particularly the anti-NMDR encephalitis that we didn't even really know about 15 years ago. And then there's what we call seronegative encephalitis. And then just to make things more complicated, there are entities that don't really cause encephalitis, but they cause a clinical picture that looks like encephalitis. So as I mentioned a minute ago, those patients don't come in with something on their forehead telling the physician what they have. So the physician has to really think, is it a rheumatological process like lupus that's presenting for the first time and happens to be having what we call a central nervous system presentation? Is it a neoplasma? Is it a weird drug reaction? Is it some genetic cause? So very, very long list of things that need to be considered. So I just want to walk back actually many years ago, over 25 years ago, when I was a pediatric infectious disease fellow at the University of California at San Francisco. I vividly recall a beautiful young teenage girl who presented to our emergency room. She'd been previously healthy. She presented with altered mental status, and she had fevers. She was hospitalized in our pediatric intensive care unit. We did the initial workup on her, and her lab work, particularly her spinal fluid, was consistent with encephalitis, which means she had some white cells, her protein was a little high. We did brain imaging on her, and it showed inflammation of the brain. We started on what we call empiric antibiotics and acyclovir. And what that means is we didn't know whether she had a bacterial or virus to treat, but that's something we never would want to delay. So we went ahead and started those drugs. And over the following days, her workup came back and her herpes virus testing was negative and her spinal fluid did not grow a bacterial. So we sort of virtually had ruled those two things out. I was really discouraged from doing any further workup on her because, a lot of the doctors said, well, listen, we've looked for all the treatable cause. What's the point? There's no point in looking further. And, I, as an infectious disease doctor, that didn't ring well with me because our job is to try to find answers, particularly infections. So over the next several days and weeks, she had little improvement. Despite being discouraged from looking for answers, I did, and I was convinced I would be able to find some, but none were found. And, I think it's important to point out, if we don't know what causes it, which is so often in this realm, we really don't know how to treat it. And even though I mentioned that we had started her on some what we call empiric antibiotics, we have a saying in medicine: do no harm. So do not just throw on drugs if you don't know what you're doing. Every drug we use has a potential downside. So in particular, back then we didn't want to just start steroids because we were really worried. Oh, if we have an infection and there's an underlying virus, it could go out of control if we use steroids. So there was a lot of reluctance back then to use steroids. And as many of you know, if we'd known it to be an autoimmune issue back then, steroids would have done a lot of good probably for this patient. But again, we didn't know what we didn't know. After about a month's stay, she was ultimately discharged to home, but she had a lot of residual deficits. She was not normal. I really, at that time, I remember very vividly, we'd failed that patient. We'd failed her family. They kept asking why, what caused this. I didn't know. We had tried, but we just couldn't find anything. And really, there were more. It just kept happening. Throughout my fellowship, there was additional pediatric patients who presented, and they weren't identical, but they often had an altered mental status. Sometimes they had really severe seizures. Sometimes they had movement disorders. Sometimes they had cerebral edema. We ultimately gave them a diagnosis of encephalitis, but we really didn't have a specific etiology that was found. And it was so frustrating. And, clearly it was frustrating to me, but I could only imagine how difficult this was for families. So following fellowship, just ironically, I ended up as a medical officer in the California State Viral Lab. And in that capacity, we were constantly getting referrals from clinicians all over the state, and because we had very specialized testing. And for certain infectious agents such as rabies, you really don't want to rely on a commercial lab or a hospital lab. They are not able to do that testing. So the state lab needs to do that testing. So we were getting referrals all the time for rabies and sometimes for arboviruses, such as even when we started, West Nile hadn't quite emerged, but it did while I was there. But that's what the testing the physicians were asking for. We did the testing, but they were rarely positive. So, I was back in that same position as fellowship. Like, what is going on? Why is it we can't figure these out? And that's really what led to the California Encephalitis Project. We felt like at the State Health Department, where we were getting a lot of referrals for encephalitis, this would be a great place to look at it. And so we went to the Centers for Disease Control Emerging Infection Program and asked for funding. And actually, coincidentally, New York and Tennessee were asking for that very same thing around the same time. So we formed this kind of a network where we shared data and protocols and try to learn from each other. And our main goal at that point was to try to find what was causing these encephalitides, with the idea that we believed that was mostly going to be infectious. They looked like they were infectious. They had fevers. They had white cells in their spinal fluid. So by our definition, they should have been infectious. And at that point, it was really exciting because molecular diagnostics were just emerging on the scene. And what I mean by that is that was when PCR, which you probably have heard about in the news, if not before, but certainly with all of COVID, that is the PCR testing is how much of that is diagnosed. But back then, in 1998, those tools were not widely available. So they were just becoming on the scene. We were going to incorporate those into our laboratory, as was New York and then Tennessee. And we were all convinced that if we use these new molecular tools, along with what we call the tried and true diagnostic serologic assays, we'd really be able to solve a lot of these cases. We're very optimistic that we could do a good job with these. We thought, we'd get a handful a month, maybe 3 or 4 cases. And that was what we were thinking back in 1998. So one of our first challenges, though, was figuring out, well, how are we going to define the encephalitis? We can't just let anybody refer cases and do the testing. We had to figure out what our case definition was. Now, you at home that are thinking about this and, figuring out, well, case definition is not really important for the patient, but anytime you do a study on encephalitis, you have to have a set case definition. So we spent hours, if not days, deliberating on a case definition that we could all agree on. And the difficulty, of course, is, as I mentioned a few minutes ago, the presentation of these cases can be so heterogeneous that having a common case definition can be difficult. We ultimately landed on something where, patients had to have a fever, they had to have altered mental status, they had to have a little bit of inflammation in their spinal fluid. But beyond that, it wasn't a very specific case definition. And in fact, I remember giving a talk once about it, and somebody raised their hand and said, well, somebody who's drunk could meet that case definition. And that is very true. But again, the difficulty in this is that these have such variable presentations. And then the other challenge that we ran into very early on that I didn't anticipate was we would find certain viruses, but we didn't find them in the spinal fluid. For instance, we would find like parainfluenza in a respiratory tract specimen or rotavirus in the stool. And so what did that mean? We didn't find it in the spinal fluid, so is it really the cause? So we had to sort of grasp with, well, maybe it is the cause or maybe it isn't. And then conversely, we found agents, particularly herpes viruses, in the spinal fluid, but we didn't necessarily think that they were the root cause of the encephalitis. And a really good example of this was there's a virus called human herpes virus 6, or it causes roseola in very young children. And in the United States, at least, by the time children are 2 years of age, the vast majority of kids have been infected with that. And once you're infected with a herpes virus, it stays latent in your body. So we were continuously detecting it, but it wasn't necessarily the cause. So we had to, and so that was the beauty of molecular techniques is they're incredibly sensitive, but the downside is that they're incredibly sensitive and they often would lead us to, areas and really people would get on the wrong path and they would want to treat these viruses that we found, even though they probably weren't causing it. So we had a lot of challenges as we had these new great tools and we were really learning how to use them. So just to kind of quickly try to summarize what our experience was with encephalitis. So, when we started, we thought, we would get a couple, cases a month. Well, over a 10-year period, over 6,000 cases were referred to us. Now, I'd love to say that's because we did such a stellar job and we were figuring all of this out. That was not the case. We figured out very few of them, honestly, as I get to that. But what it was is it showed the incredible need out there. Physicians, families, they were desperate to find answers. And so they were working with us. And we weren't easy to work with. We required all kinds of specimens and paperwork and everything else. But, physicians were just so desperate to try to figure these out. And of course, as I've already alluded to, we identified a lot of limitations of the molecular testing. We found false positives. And actually, in some cases, that led physicians to treat with drugs that was probably doing harm to the patient. And we also learned that despite, for herpes, it's a very good test and treating spinal fluid. But we learned, for instance, in pediatrics, there was a lot of false negatives for herpes in that first spinal fluid. So we had to learn when maybe spinal taps needed to be repeated. We also learned that spinal fluid wasn't always the best test. You often had to look in other sites. So, we had a lot to learn. And I think one of the big surprises of our project was that we learned the spinal fluid, or that there wasn't any new pathogens we were finding as we thought we would find. We actually had done a lot of pathogen discovery. And then the saddest thing about our project is we found a lot of unknowns. Over 50% of cases didn't get a diagnosis despite really extensive testing. One of the things we did observe, however, is that this truly was a heterogeneous syndrome. And while all of our cases met a common case definition, they were very different from each other. For instance, we had one group of patients that generally presented with a high fever, edema or swelling of the brain, and the swelling was so bad and so fulminant that over a 24, 36-hour period, the brain herniated. It basically kind of exploded, and there's no room for it to explode within that skull, and they died very quickly. These were incredibly devastating cases. There wasn't common, but they were notable when they came in. There was also a group that was quite different from that presented with seizures, just intractable. And the seizures were so bad that the physicians often put them in a coma to control that seizure. And every time they would try to lighten the coma, that the patient would seize again. And that was clearly different than the patients that presented with movement disorders. So we began to group these together, realizing that, really emphasizing this was not just one unique encephalitis presentation. There were many different presentations, and really to try to tease them apart would be the best way to try to solve them. So I talked about a lot of the challenges. I do want to talk about some of the, wins in this area, and we really have come a long way from where I started as a pediatric fellow. And I think one of the first wins we had was when we started to collaborate with Joseph Dalmo. And for those of you who don't know who he is a brilliant, incredible scientist and neurologist. And he's the one who actually discovered anti-NMDAR encephalitis. And this is the type of encephalitis that the book Brain on Fire, that patient was infected with. And back when we were early in the days when we started this project, Dr. Dalmo had just discovered it and was just in a handful of patients. In fact, he discovered it primarily in young Asian women. And when we started to work with him, he was finding it in all kinds of our patients, and our young patients and our older patients. They didn't have that associated teratoma or tumor that was originally discovered. And really, we were kind of shocked because we weren't used to finding much of anything. I mean, we had so many negatives in our project, and we were just stunned with how many different cases were positive. And then even with that collaboration also led to additional types of autoimmune encephalitides being found. So all of these years we'd worked on it, and we had assumed that these cases were infectious, and we kept looking for infections, and we would look deeper, and we would look for other types of infections, and we would relook for some of the same infections thinking we missed it. Well, the reason we missed it is it wasn't there to be found. It was an entirely different category that we hadn't really considered until we started to work with Joseph Dalmo. And of course, he has gone on, and he has just been brilliant in this area, and this is probably the biggest change in the area. So it's ironic that when I was working with this, I assumed we would find new forms of encephalitis that were infectious, but primarily what's been found is new forms of autoimmune encephalitis. And part of the reason this is so incredibly important is that back when I was a fellow, we tried never to use immunosuppression or steroids, because we thought, if a patient has a virus, we're going to make it much worse by using steroids. And so indeed, those patients probably would have done better if we'd known that this was an autoimmune phenomenon. And another thing that I would consider a major win in this area, or an advancement in the area of encephalitis, is basically the percent of cases that now have an explanation. And as I mentioned with the encephalitis project, we had less than 50% that we could explain. But Dr. Phil Britton and his team in Australia, and he talked earlier in this symposium, he recently published an article of childhood encephalitis from many centers in Australia, and they were able to find an etiology in over 80% of cases. So this is just an astounding accomplishment. And again, it really shows how far we've come in the field. And then the other thing that I would consider a win in this area is that just having a common case definition where people that investigate it can use that is a big advancement. As I mentioned early in the encephalitis days, we struggled with finding a common case definition. And the importance here is that this is really makes studies comparable study to study. And so it's really a great win. The other thing the International Consortium did is they came up with what we call these diagnostic algorithms, so that physicians can go to that and kind of go through what we call the tier 1, tier 2, and even tier 3 testing of what should be done For instance, every patient should have herpes testing done. Every patient should practically should have autoimmune testing with NMDR done, just because those are so common. And so we really go through those in those algorithms, giving physicians some place to go, because in the past they would go to textbooks and they would look at those laundry lists, just like I started at the beginning, and that's what they were faced with. And these diagnostic algorithms will kind of go through, well, if a patient has movement disorders, you should also add this. If a patient has certain findings in the spinal fluid, then other entities should be tested. So that has been a huge advancement in the field. And then, as I've already talked about, autoimmune encephalitis, which was really barely a footnote when I was training, a footnote in textbooks about encephalitis. We've come over the past 20 years so far from basically having maybe 2-3 publications a year to many hundreds of publications now, really just showing this outstanding work that's been done on it, with both recognition and with the treatment of this entity. I'm going to switch gears just for a minute. Becky Dennis, when she asked me to put this together, really thought that it would be good to spend a couple minutes on some of the outcomes and recoveries of encephalitis, and really to speak to the parents who have children with encephalitis and struggling with some of the things related to that recovery. I think just to step back for a minute and think about, when we talk about recovery and outcomes, we have to remember and we have to think about encephalitis as a type of a brain injury. And it's unlike many infections that we deal with, it's not simply just you treat it, it's gone, it's done. It really is this brain injury. And in thinking about that, we have to remember that the speed of recovery, how much residual deficit will be left behind, and even whether relapses will occur, really is going to vary depending on what kind of encephalitis somebody had. And I'm going to go through a couple studies that talk about outcome measures that we scientifically look at with encephalitis. But we have to remember that those outcome measures, and one of the famous ones that use is what's called the modified Rankin score. That score, unfortunately, doesn't really capture some of the cognitive and the behavioral issues which we need to think about with encephalitis and the recovery. And really, those are what's such a primary concerns to the patient and the family. I would say, just as a backing up just a bit, before a patient is discharged with encephalitis, people should think about at least going through a screen, not a formal evaluation, but a screen to look for some of those features that would happen on a formal evaluation. And I'll get back to that. But before discharge, an eye exam, seizure evaluation for seizure, speech, and OT therapy, making sure somebody can swallow okay, spasticity issues should be addressed. You should make sure that there's no skin issues or breakdown of skin leading to pressure sores. And nutritional needs are incredibly important. So there's a lot, by the time somebody's been in the hospital, child came in potentially very, very sick, and they're ready to be discharged, everybody is just over the moon that their child's done so well. But very important to make sure all of these things are addressed before that patient is discharged from the hospital. And also just to remind people that the outcomes in pediatrics are going to be different than adults. And as tempting as it is to think about children as little adults, they are not. They're different in many, many ways. And one of the good ways they're different, at least when it comes to outcomes, is that there's a lot of neuroplasticity in children's brain. So even though their brain may have had a very severe, what I would call a hit, very severe damage, because of that neuroplasticity, children often do so much better than we think that they're going to do. And I would say that I time and time again, particularly with some of the autoimmune encephalitis and the anti-NMDR encephalitis, there's been children that have been incredibly ill in intensive care for days, if not weeks on time. And I've kind of thought to myself, well, that child will never be normal again, if they even live. And they've made some of those kids have made a phenomenal recovery. But importantly, that recovery has been slow. We traditionally think, well, usually by 3 months, you'll get a good sense of where they'll be. 3 months is not even you haven't even begun the path of recovery in some of these kids. So I think it's really important to remember that, with children, that recovery can occur months and years after the initial insult. And really, when I'm often asked in the hospital, well, what's going to be the outcome? What are the predictors? And I think it's always important to say this is a very heterogeneous syndrome, and the outcomes are going to depend very much on what was the cause. For instance, rabies is 100% fatal. The outcome is horrific, and that is unfortunately just where we are with rabies. It's unfortunate we haven't made more advances. With herpes simplex in children, they often survive, but they may have chronic residual problems. With West Nile virus, which doesn't usually cause encephalitis in children, but when it does, the outcome is usually good, and that's different than in adults, of course. With enterovirus, which is one of our most common causes of encephalitis, it actually depends on which type of enterovirus caused that. For instance, if it's Enteros 71, the outcomes are usually pretty bad. Where if it's other types of encephalitis or other types of entero, the outcomes are generally much better. And just keep in mind, with these infectious causes, assuming that child's gone home from the hospital, setbacks are not uncommon, and that a child may be doing great, but you may then begin to see them slip back a little bit. And that's not, to be a failure at all. It just means we probably have to readdress a problem. With the autoimmune diseases, the outcomes, depending on which autoimmune, but particularly for anti-NMDAR, these individuals have a severe presentation, very significant. They're in the intensive care unit, but a lot of them end up having a full recovery, although relapses can be common. And then if your child's fallen into what we call this unknown group of where we look for the cause and we weren't able to find it, this is such a heterogeneous group. It's really impossible to predict how that a given child will do. Now, if we look at some of the studies, and it's almost, your eyes may be glazing over, and we look at outcomes, because that's when we're asked as clinicians, well, how is this child going to do? We look back on our own experience, but we also look back on what the literature has told us. I just want to walk through a couple studies about the outcomes, but pointing out that each study used a different case definition of encephalitis. There were different causes, and there was variable time of follow-up. So in some ways, it's hard to really know what these studies are telling us. There was a study at one center in Colorado looking at children between the ages of 0 and 21 years. They had about 50 patients in that study. Little over half didn't have a known etiology. They followed those over about a year after the presentation, and about 3/4 had some sort of persistent deficit. There was another study done out of Netherlands where they looked at ICUs, children that had been admitted to the ICUs with over 100 children. Most did not have a causative agent. And really all they could really conclude from their outcomes that they had higher death rates in those very young children. And then finally, in a more recent study from Australia at 5 of their major centers, they had over 200 children, and about 1/4 of them had some sort of what they would classify as a moderate to severe neurodisability at the time of discharge. Now, the study I'm most familiar with is a study that we did here in the Bay Area in California, looking at a very large center that has over 190 beds, 23 intensive care units. And we looked over a period of almost 10 years. And there were about almost 200 children that we could evaluate their discharge. Next slide. And we did this by the traditional modified Rankin score. And, we found that about 7% had died, about 10% had a severe disability, and almost 17% had a moderate disability. But the good news here was over 65% had had recovered, according to our way of looking at this. Next slide. But I think, for those of you who maybe are dealing with a loved one with encephalitis, or you yourself have been affected, and you think, oh gosh, I was told I recovered, but what does that really mean? And I think what's the problem with all of these outcome studies is we don't capture some of those more important, some of these things that are more nuanced. And we know that encephalitis is often somewhat of an invisible illness. There's so many things going on that clinicians can't recognize. They don't necessarily know that somebody's dizzy or has chronic headaches or light sensitivity or even blurry vision. And so, or even sleep disorders. These are not captured in a lot of the kind of outcome measures that have been done in these studies that I just alluded to. So I think we really need to get better at identifying some of these more subtle things that don't have such subtle consequences in our survivors. It's also really important. So the neuropsych evaluation is going to be incredibly important. And this is something that can't be done at the time of discharge. Now, I mentioned a screen should be done, so somebody should sort of be paying attention to some of these things, but that formal evaluation shouldn't take place for at least 3 months, if not closer to 6 months after discharge, because the brain is still recovering at that time of discharge. There's still may be some swelling and inflammation. And so what this neuropsych evaluation does is there's an evaluation of all kinds of things. It's not just about the IQ, but it's about the attention, the problem solving, memory, language, visual, spatial skills, academic skills, and even that social emotional functioning that often can take such a hit at the time of this diagnosis. And this is very different than the kind of tests that the child got while they were in the hospital, such as the EEG or the neuroimaging. And these results can really clarify more diagnoses that may be related to learning. And really it's sort of caused this diagnostic conceptualization where if you can really pinpoint that problem, you can go after it and address it. Next slide. There's also a gross motor skill. It's called the WE-FIM system. And this is a tool that is used by particularly rehab doctors to try to assess. So in those very young children, this may be an important tool to measure really just, particularly for those young children. Next slide. So, and one of the things we hear is after kids go home and they presumably doing really well with the encephalitis is, we hear that, they're not doing so well in school. And so I think we have to always look back and say, well, is it, there's so many different reasons, and we shouldn't just assume it's because, their brain was injured and therefore they're not going to be able to learn. Well, if they're having subclinical seizures, we can address that. And that may be the reason they're doing poorly. Are they having depression? Is that a part of it? So we need to address that. And if I want to just mention that with children, we don't see the degree of depression following encephalitis that's seen in adults. So it can be seen, but it's not necessarily super common. What is common is children may develop an attention deficit disorder that they didn't have before that diagnosis of encephalitis. It may be medications that is causing it. And one of the things we often hear about is that children that have encephalitis that may be in 5th, 6th grade, they seem to go back to school, they're doing okay. But then a few years later, when they get to high school with more sort of complicated issues, they may start having problems. And so people are confused. Well, why weren't they having problems before? Well, it may be that their executive function abilities have really are a problem, but that wasn't noted earlier because getting through maybe 5th and 6th grade doesn't require those skills. But by the time they get to high school, that's a skill they're going to need. So there's so many different things that can emerge either just after the diagnosis or even a few years later. So we need to keep coming back to why are these things happening? Because there's a very good chance they can be addressed if we can identify it. Next slide. And so with school issues, I would encourage people just continuously reevaluate, try to figure out what is at the root cause of that. Even if a neuropsych evaluation was done, after discharge, maybe a couple of years ago, your patient or your child may benefit from a reevaluation with encephalitis, and an educational plan will be very important. And really importantly, trust yourself. If you think something is wrong, don't give up. Some of the problems can't be fixed, but there's a lot of areas where intervention will make a big difference. And don't be afraid to ask for help. Next slide. And really, I just want to, this seems so obvious, but I think we just have to say it. It really takes a whole team. This can be an overwhelming process. Obviously, the parents are going to be critically important, other family members. Your pediatrician may be your best friend here. They may really be able to help you navigate the system, or a pediatric neurologist, a psychiatrist, the rehab team, rheumatologist, a psychologist, a case manager. And then really something that I'm not really that familiar with, but I've been told by my pediatric neurology colleagues that finding a good educational consultant is really important for some of these patients. If you get a good consultant, sometimes they can identify a better school placement. They will really be an advocate within the schools for you. They'll be able to work through so many of the struggles. You can't do this alone. Many of you aren't familiar with some of these problems. So you need a team that can really take a very holistic approach. And I think one of the challenges, of course, is that we have to have a multidisciplinary approach. If you're seeing the neurologist one day and a psychiatrist on another day, and they're not talking to each other, that's a real problem, because one specialist may think it's the other one's job, or they may think they're addressing it. So I would really encourage you, if you're not already dealing with a team that is having a very holistic approach, to try to advocate for that. It's not unusual that, we often, family will say, we want everybody to meet as a team, and we want to address all these issues together. And really just have to say this seems obvious, but don't forget to take care of yourself. This is an incredibly stressful situation. It's not just while you're there in the ICU or the hospital. It remains stressful after you go home. It can be difficult on relationships. It can compromise your health. And really take time out for yourself. You're not going to be able to be as helpful to your child or the other individual if you haven't taken care of yourself. Friends and relatives, they want to help. They just may not know how. So you need to learn how to ask for help. And I think to remind you that there are a lot of families out there who've gone through similar events. They've struggled through these things. Don't try to do this alone. As a physician, I can tell you my experience of patients in the hospital, but I can't be that same resource that families that have gone through this can. They can help you navigate some of the things that I'm not even aware of. So don't be afraid to do that. Back when I was training, we couldn't send families to this. We didn't have the internet to go have them talk about this, whether it's on Facebook and the World Encephalitis Day Alliance nonprofits. This is why they formed together, is they knew back then that there wasn't that support. We know that is tremendously helpful. And just now, I'm going to last minute, where do we go now? Well, I think we have to recognize with everybody that encephalitis is a brain injury. We have to really treat it more like we do with stroke and traumatic brain injury, where there's rehab guidelines that are really focused to it. We need better therapeutics, particularly for viral agents. That is an area we haven't made much advancement with. Acyclovir is still the drug we use for herpes, and it's certainly better than not treating, but it's not that great. And why don't we have a drug for enterovirus encephalitis? It's the most common cause in pediatrics, and yet there's not a single drug we can use for enterovirus. We need to continue to collaborate on rare forms of encephalitis, both for the diagnosis and management. And most importantly, we need some dedicated funding for this field. This field is just doesn't have much in the way of funding, and without funding, particularly for such a challenging syndrome, it's hard to make many advancements. And I want to acknowledge Becky Dennis. She's really been a tremendous colleague to work with for many years, particularly as I went through trying to figure out, what you might be interested in hearing. Ariane Saldatis is a pediatric neurologist at NIH and really has given me a lot of good insights of things to talk about, as well as Benjamin Mandek, who's a pediatric physical medicine and rehab doctor. And then, of course, the entire World Encephalitis Day Alliance. I really thank them for everything they're doing on this really devastating syndrome, but where we've come a long way. And you could skip that slide. And I think we're for Q&A. And I have not been monitoring chat questions. So.
All right. Can you hear me?
I can.
Okay. I can't get my video back on, but that's okay. We have one question about autoimmune encephalitis. And the question is, what % of people have a monophasic illness versus have a relapse?
Yeah, that's a great question. So we don't really know exactly how many will just have that initial one and then have a relapse. I think it's probably about 20 to 30% of individuals that have that initial autoimmune will end up having a relapse, but that's a little bit dependent on which of the type of autoimmune, because I kept referring to the NMDAR type throughout my talk, partly because that's what I'm most familiar with. And in pediatrics, that's the most common type. But there are dozens of different autoimmune types. So it will be a bit dependent on which type of autoimmune.
Okay. And the next question is, somebody has a 5-year-old and had severe MOG ADM.
Uh-huh.
He has made a near full recovery. An MRI almost a year later showed mass loss in the brain. Are children able to compensate for this as they grow up?
Yeah, so basically, well, I'm very happy to hear that he has made a almost full recovery. And, hard to know. It's hard to know, depending on how much that mass is and is it 5%, is it 30%? But as I mentioned, children have this amazing neuroplasticity to their brain. So we are often pleasantly surprised and wrong. We'll often predict a child's going to do worse than they ultimately do. So it very, very hard to tell. But the fact that the child's done so well, that would, I think, really, speaks to probably a good outcome, and that there has been neuroplasticity. But as I mentioned, there may be certain problems that arise that aren't noted now. And so always be revisiting that neuropsych evaluation to sort out, because there is probably going to be some deficits that may not be noted now, but get noted later, and to try to address it and see if we can at least treat that particular problem.
Great, thank you. And one person asked a question that you and I were actually talking about a few days ago. And the question is, what does having a relapse mean?
Sure. So a relapse, so I mentioned, kids can have setbacks, but then I also mentioned relapse. So setbacks is when somebody's had like an infectious encephalitis, they're doing pretty well, but then all of a sudden they start having really bad headaches or maybe even having seizures. That is a setback. I wouldn't call that a relapse. A relapse is something we see within the autoimmune type of encephalitides, where basically the immune system is sort of, decided to do its ugly thing again, and that patient may need more immunomodulatory therapies, whether it's steroids or another drug. So it actually is like, I don't like to call it quite a recurrence, but it's almost like a recurrence. And that is different than the setbacks we see with the infectious causes of encephalitis.
Okay. And in your experience, have you seen children with psychosis present with a specific difficulty recognizing their parents or other people close to them?
Yeah, that's a great question. So that is indeed one of the types of presentations that children can have when they present is really a psychosis, and where they don't recognize who their parents are, or where they are. So that is and of course when you have inflammation of the brain, particularly to certain structures, that is exactly what we see, and it can be seen in many types of encephalitis. Unfortunately, it doesn't really help us figure out, is it an autoimmune one? Is it infectious? I mean, in fact, rabies, that's classic for rabies, is a really profound psychosis. But certainly in most countries, rabies is very uncommon. I will want to just remind people of that. But, that's just gets to the difficulty in evaluating this whole spectrum of illnesses. You really have to evaluate, is it infectious? Is it autoimmune? And go down that path.
Okay. And another question from our audience is just how to get doctors to work together as a team. So you had the slide with the finger pointing, um,
Yeah.
but a lot of situations, the parent only can talk to one doctor, and then they'll report to the other doctor what they said. So, how do you come about bringing that team together?
Yeah, that is a classic problem. That's not unusual. It's easier when a child's in the hospital. That's we will often, and it's often on the parents' request, is they'll ask, the whole team sits down. They'll have a family conference, sits down with them, goes through their list of questions. And by the way, it's often nice to have a either family member or friend often there to take notes, because so much of what we say in medicine, we get into jargon sometimes, and you can be a little bit overwhelmed with the jargon we use. We try not to, but we do fall into that habit quite frequently. So, but once your child's gone home, this is where, maybe you have somebody within the medical system who's truly an advocate for you and can kind of pull people together and say, hey, we're getting mixed messages. The neurologist is saying this, the psychiatrist is saying this. We really need to get on the same page. I'm not saying it's that easy, but I think sometimes requesting it requesting that you have a group call together, at least, not necessarily physically in person, especially these days, but that everybody's busy. Everybody, takes time out of their schedule, but sometimes that in the end may save everybody. And communication, not just from the doctor to the patient, but between the doctors, is so key in these cases. And not easy. I'm not saying it's easy, but I think you as a parent have to push that, because your child will only benefit from it.
Okay. I think we have time for one or two more questions. Another one is, most examples were given were anti-NMDA. The question is about how the patient with Casper-2 recovers and the possibility of relapse.
I'm a little bit familiar with Casper-2, but I don't have any. So I'm not gonna try to answer that, because I think it would just not be an honest answer. So I haven't really reviewed the literature on that in pediatric encephalitis. So I would say your neurologist, hopefully, or maybe your rheumatologist may be able to give you more insights. And I can even dig into it and try to get back after this by looking at the literature.
Okay, thank you. And then one last question. One person said they really appreciated you sharing the wins in terms of where we gotten to be in terms of encephalitis now versus 15 years ago. They were asking, what is the most significant one in your mind?
Well, again, I think they're all significant. Just again, having, when I was a pediatric fellow, and that was part of the reason I was sharing with you all of those frustrations. But I think, and even though I wish it was in the field of infections that the biggest win, but indeed the biggest win has been in the field of autoimmune encephalitis. In some ways, that's a win for us in infectious disease. So instead of keep banging our heads against the wall looking for infections when they weren't there to be found, it is a win for us. But it really has changed the course of this. When I was training, we would not have treated those kids with immunosuppression, because we wouldn't have known. And because we were all so afraid, if there's a virus and you give them steroids, you're going to make it worse. But now I think people are very eager to use steroids as soon as they've very early on, which is good. So that is a tremendous win. And Dr. Damo and others are really to be congratulated on what he's done in this field, and many others.
Awesome. Well, thank you so much. A very candid discussion. I think it's very welcome from everybody, especially knowing some of the progress that's been made over time. I know our listeners really appreciate your perspective. We realize that no doctor can know everything, so it's refreshing to hear from a doctor of your vast knowledge, just recognize that we still have a lot to learn. So thank you so much, Carol. And at this time, I'm going to turn it over to my friend and Alliance colleague, Nazrin Shaheen. She's the president.
Thank you. Thank you for all you do with this syndrome.
All of us are working hard together, aren't we?
I know it. Congratulations on this great conference. Bye-bye.